they've tokened it fundamental pain bias. And basically, it's this phenomena that, or this false belief that other people exaggerate their pain, that you know your own pain, but other persons exaggerate their pain. It's just very interesting that we have all of this data, and yet we still undertreat all persons' pain. And then more so if you're minoritized. What is the harm in believing someone 6 is a 6 and treating that as a 6? My background, I guess, is in pre-hospital, that's why I'm on the podcast. I also have a bit of knowledge and understanding in equity, diversity, and inclusion, or DEI or EDI, however you want to spell it. And then a specific interest in education, largely interdisciplinary education. And I'm very honored to be here today. Thank you for asking.
This is perfect, because when I was thinking about who can I grab that's an expert and all that, and analgesia, you're the first one that came up. And I haven't told you this, but this is funny, that the first time I met you, I was so intimidated of you.
Oh God, why? No one should be.
Because highly intelligent, highly successful. I was like, I should not be in this room. But the best part about it, when we got to know you better, it's that you're the most down-to-earth person I've ever met.
Yeah, no one should be intimidated by me. Ever. It's frightening. I walk into a room and I'm often like, God, why are these people listening? And then I'm like, well, okay, fair. I do have some relevant knowledge in the area, but I'm very humbled to be here. That's very, very kind of you to say. Yeah, it's usually a pretty good room to sit in if we're both in it. So some experts in there as well.
Yeah, and when Morgan's there, like, just love when all of you are there and I can pick all your brains and learn something. So I'm glad you came on, because we're going to talk about analgesia.
Very important topic. You and I were just speaking beforehand about the fact that it's a huge preponderance of the calls that we see and that we do pre-hospitally, and yet there's really this kind of dearth of specific teaching around the areas, adequate pain control, how we assess for pain, what we do with pain when it's present, because often, as we know in the pre-hospital setting, our hands can be tied in numerous ways. And so it's the more you know about what you have in your armamentarium and the more you know how to adapt each tool that you use, the better we can serve the patients that we're treating, the better these calls go. And then I think the just more equipped we feel when we respond to subsequent calls. So happy to be here.
That's such key points, because I'm just thinking from your unique perspective, you have pre-hospital experience, but also you see in the emerge, like, were they treated well? Or were they have a suboptimal dose? Or did they receive maybe the wrong analgesic medication? So can you maybe delve into some of your experience and how that could translate to paramedics in their perception of analgesia?
So I have the beautiful benefit of, in some ways, keeping these patients for many hours and seeing how they do, after doses have been given pre-hospitally. Either, was it too much? Was it the right dose? Was it the right analgesic, like you talked about? A lot of pain assessment that we do is often a reassessment if we think about it once we're in the department. So I have the awesome benefit of either getting to see a patient who already has these analgesics on board and getting to, they're already into effect. I don't have to wait that 30 minutes for the oral dose of something to kick in. It's already there. It's been given. And then I get to up titrate with higher potency, or I get to reassess and give another adjunct or redose if indicated. Or I get the added benefit of seeing how they responded to the initial dose, which is huge, because a lot of, even in our directives, it says, if we think of the opioid directives, was there hypotension secondary or subsequent to that initial dose? I know whether or not they're going to be hypotensive or drop their pressures, or have we filled them up with, adequate fluid recess, and now we don't have that drop in the SBP. So within the emerge, not only do I have the benefit of reassessment, but I have all the other training that I received in my career and getting to work with different providers and understand how they use analgesia, particularly if we think about like acute pain service rotations that some of us did as part of our anesthesia blocks, or working in the trauma room and working with different adjuncts that we use within those controlled and nuanced settings. So then we extrapolate that to how we manage pain, how I manage pain within those settings in the department. So I really get the benefit and got the benefit of working with different providers and seeing which adjuncts they use. which I think is particularly why I love some agents in some settings and not agents in others. I also get the benefit of giving these meds in a much more controlled setting with many more providers, with almost whatever I request or ask occurring. Serial vitals Q15, great. Second line, sure. IV access, absolutely. I am incredibly lucky to work with the care providers that I work with, and that they make those things happen. So I have a great ability to control pain. But even with all of these hospital, even with all of rather these physician, I don't know, caveats or whatever you want to call them, in the in-hospital setting, there's still great data to show that we don't control patients' pain well. So if I am failing in hospital, if we as the hospital docs are failing, how can we expect 100% success rate in the pre-hospital setting when the resources are so much more limited and the setting is so much less controlled? So it's something that I think we all struggle with in terms of the, healthcare providers in general, but there are certain nuances and tips and tricks that I picked up along the way that I think could be extrapolated to the pre-hospital setting just to have a better, more robust response to patients' pain.
Why do you think it's unanimous that whether it's in hospital or pre-hospital, we undertreat these patients despite all that education experience?
It's a great question. So in preparing for this podcast, I came across this paper by Boring et al. In 2022, and it was published in the Journal of Pain. And it really outlines this phenomenon beautifully. They've tokened it fundamental pain bias. And basically, it's this phenomena or this false belief that other people exaggerate their pain, that you know your own pain, but other persons exaggerate their pain. And it was a journal, the research and everything was out of the US, so extrapolated to us, but not necessarily globally if we think about how we can look at what those results were. But it's this like huge cultural belief that other people generally exaggerate their pain. And this was looked at in healthcare providers, in non-healthcare providers. And even though there's phenomenal evidence in the pain world, which is a multidisciplinary world, that self-reporting of pain is like the best standard that we have. It's the closest that people have to actually experiencing it. So it's the most proximal assessment that we can do for this subjective feeling is someone's self-reported pain. And these tools are all validated internally, externally, in the pre-hospital setting, outside the pre-hospital setting. And yet we found that healthcare providers underestimate or disagree with people's reported pain, or we feel that people don't understand their own pain, which is like wild that we disagree with someone's ability to perceive what their own pain is. And I can certainly think we've all been there, right? The patient comes in, they've stubbed their toe, they're sitting there texting. You ask them, what is their pain level? They say a 10. We know that's not a 10. But I think that there is a huge phenomena that we extrapolate that as the general and that as the normative, rather than the person that's there with chest pain saying, I have 8 out of 10 chest pain. And we say, they only look like they're feeling a 6. They only look like they're feeling a 5. So there's this huge world that we've been raised in, even before we become healthcare providers, where pain is something that people exaggerate or overfeel, which is very interesting. Because if you think of the quality, which is like the farmer, anytime a farmer calls 911, we know it's going to be bad, right? A farmer says pain, it's bad. It's a 10. It's a 10 automatically. So it's just very interesting how there are all these interplays about our lived experience that we bring to the perception of our patients. And there's this huge transference and countertransference in terms of how we rate and how we perceive what someone is feeling. It's very interesting. So I think one, it's like there's a huge stigma. There's a cultural stigma about it. It's our understanding and our learned feelings and perceptions and reporting of what pain is. And then there's us as healthcare providers and clinicians, whereby I think we think that we can perceive patients' subjective symptoms, which are always subjective, but a patient's symptoms as something when they're not. We can kind of change what they report. So that was certainly a new point that I learned in prepping for this.
So to make sure I hear you correctly, because I'm having light bulb moments too. We are taught patient's pain subjective, but then again, we are subjectively putting our biases on the patient's subjective experience.
Yes. Yeah. We then internalize what they report and spit out this outcome, or this number or this pain value, which we then treat. So there's so many layers of, so many filters, I guess is the better term, that go into this perception of what someone's pain is before we spit out what the outcome is going to be. And it's interesting because there are huge, if we talk about biases, if we talk about illegal analgesia, if we talk about certain cultures that tend, or races, genders, ages that tend to consistently receive inadequate analgesia, it's non-white populations, it's Black populations, it's Latinx populations, it's children, women, it's any kind of minoritized group systemically and systematically is undertreated in terms of their pain. And it's just very interesting that we have all of this data, and yet we still undertreat all persons' pain, and then more so if you're minoritized. It's just this really interesting cultural phenomena that we do.
That's a perfect bridge into mostly like why we're here today, because like you're saying, there's a lot of empirical evidence to suggest we always undertreat these subsets of the population. So if we look at the elderly, why do you think we undertreat the elderly?
So, I mean, multifactorial, right? Like if we're thinking about just an older person without any of the other communication limitations that might come with age, we're reticent to know if they know their health history. We're reticent to know if they have any of the contraindications to give. We're afraid that if we gave something, and then, we found out they had renal impairment later and we gave ketorolac, we're going to be slapped on the wrist for that side effect versus, are they on an anticoagulant? Did they forgot to disclose that they were on an anticoagulant? There's all these reticent fears about whether or not they know their own health history. And we know, generally speaking, a lot of our patients, their health literacy might be on the lower spectrum. So there is some hesitancy unless we can see it in front of us, what their pills are, whether or not we believe that they're fully reporting it. Or my favorite phenomena, of do you have any medical conditions? No. And then the whole blister pack of medications is rattling like a Skittles pack, right? So I think there's hesitancy to there's hesitancy to fully put full weight or trust in what the health history reported by our patients is. And certainly there's a bias with age that we start to trust those persons less in terms of what they're reporting. And then if we layer on other communication limitations, and communication is the ability to communicate verbally is a huge necessity when we're doing pre-hospital pain assessment. If we think about the pain scales that we often use the numeric rating scale, particularly when you're outside of the pediatric demographic. And that needs the ability to communicate. I need you to tell me you have a 5, a 7. I need you to understand and internalize the questions I'm asking you, and then give me a number that is both precise and accurate. And so that can dissipate when you have a patient with advanced dementia, when you have a patient who is non-nonverbal, when you have a patient with a head injury from fall from standing, and those mechanisms of injury increase as you age. So there's a huge set against you, or the huge hit against you as you age, for us to accurately assess your pain and then to treat your pain. So it's just a compounding issue on top of already knowing that we don't treat these people's pain well.
I'm so glad you said it like that, because there's so many nuances to it. And of course, no one is saying like bad paramedics, bad doctors, bad nurses, like that's on you for undertreating them. It's look how much they care, and how everyone has to think about, okay, your age, what drugs are you on? Do you know your medications? Like, I don't want to give you something if it causes adverse outcomes. So that's so interesting that we have all these barriers in place, and it's very hard to navigate.
It's incredibly hard to navigate. As again, I was prepping for this, I came across this really interesting paper, actually out of I think it was out of Hamilton and McMaster, a couple of the co-authors, but it was published in the Australasian Journal of Paramedicine. And they were looking at barriers to oral analgesic administration. And it was interesting. They broke it down into patient factors, medical directive factors, and then paramedic factors. And they are IPSA QI paper, and they looked at a lot of different testimonials from patients and then some abstracted themes about it. And one of the very pervasive themes was fear or hesitancy, almost like this reticence to complete an error of commission. Meaning, like, I don't want to do something and have a bad outcome rather than I don't want to not do something and have a bad outcome. Do you know what I mean? The error of commission versus the error of omission. And a lot of it was an error of commission. Like you said, it is people who are primed to want to help and do the best they can and not wanting to cause harm by doing something. And so from an abundance of caring, not giving a medication, I think is a great way, because we're reticent to cause harm. We don't want to inflict harm when we already know someone's in a vulnerable state there in front of us.
What a beautiful way to say it. And I could tell you anecdotally, I'm sure we all have seen this, like people literally staring at the medications like, I want to give you something, but I'm unsure. And I feel terrible. I could go either way, but I'm just going to cautiously withhold it in case I do cause that commission error.
Yeah. Yeah. And I mean, I get the luxury of, being in hospital and getting to do a deeper dive in that past medical history, or getting to see that tincture of time where they didn't drop their pressures, or getting to, being the physician, getting to recognize that there is that risk, do some shared decision making, and then elect that the benefit of giving the analgesic would mitigate or potentially outweigh the harm or the potential risk profile or side effect associated with it. So certainly being that provider and not needing delegation to do that gives me a greater, as I'll keep saying it, but a greater tool in my toolkit. And often I find sometimes when we're patching, or sometimes when you're being the receiving physician, sometimes our physicians aren't as reflective in that nature, and they're, quick to judge, why wasn't this given? Why wasn't that given? And they don't have the ability to recognize that their lens as a healthcare provider is very different than their lens as a paramedic, even though we stock the same medications, even though we understand the same mechanism of action. So I think that also definitely would contribute to my reticence. And I'm going to say, as a medic, never in my life have I been a medic. Great profession. I do not have the skill set to do it. But that would limit me if I got, slapped on the wrist by a physician because I gave ketorolac to a patient. And how did I not know they had a big thigh hematoma? How did I not recognize that as a bleed? I would be reticent the next time when I saw that gross deformity in the limb to want to give that ketamine again. So there's this whole, again, we're going to talk about lived experience. There's this whole experience you have as a healthcare provider, which influences whether or not you're going to want to give a medication again. And I go back to the fact that you need to really understand what each medication does and what you want each medication to do, to be able to layer them and to be able to give them in the right way to achieve the goal you want, which is analgesia in the patient in front of you.
I love the human aspect of that too, because I always thought about this. I'd love to hear your opinion, that we've all been there. We've all been yelled at for a mistake or potential mistake. Yeah, we've probably yelled and given slack to someone for maybe doing something similar. In the grand scheme of things, isn't that bad. And then it just perpetuates. And the vast majority of people are going to internalize that and now be overly cautious and concerned that they're going to mess up forever now.
Yep. There's a phenomenal podcast I was listening to, EM Cases. I'm sure we all listened to it, but they had these two great hosts on, and they cited this old study about basically looking at ED physicians and whether or not they would call for help in a dangerous airway scenario. And most of them would not call anesthesia. And the people that they looked at who wouldn't call anesthesia reported one negative outcome or one negative interaction with an anesthetist. But the average time period from that negative interaction to when they wanted to recall, it was 10 years. Being yelled at one time 10 years ago precluded a physician from calling for backup for a serious airway. And that lasted for 10 years. So if we think about how impactful those interactions are, particularly when there's any kind of power discrepancy, consultant, ED physician, paramedic, senior physician, junior physician, whatever you want to shake out that power dynamic to, how impactful those negative interactions are in shaping how we treat people and how we care for people. It's a very interesting and powerful thing that you need to be really reflective of, to recognize that you don't let those shape your future interactions. Or maybe they should, who knows?
How do we get around that?
I mean, the reflective practitioner, all of this is going to come back to being a reflective practitioner as we go forward in like competency-based education. And as we move forward in what we know about education, it comes back to really being intentional with your practice, reflecting on your practice, and then digesting that interaction. Was it that the treatment was inappropriate? Was it that the human factors associated with that healthcare provided was inappropriate? Looking at, what the outcome, if it's a human factor, was it the communication angle that could have been handled better? Or was it the situational awareness that could have been better? Was it the decision making that could have changed? And I mean, I'm talking about things that we all talk about in global rating scales, but there's a lot of interplay in terms of how we digest our interactions and how we process our treatment in terms of patient care, because it's patient care, right? It's the medication we give, but it's also how we give it that really influences what someone's outcome is, or what someone's perceived outcome is.
Yeah. I think the best thing that I've had such the privilege to do this, to like interview you and other specialists, is that they all have the same theme, that they're like, this is my field of expertise and everything else I'm not in. And just the humility that even the best physicians have, and just saying like, I've messed up. This is my area of expertise, but I don't know everything. So I think that's good to discuss the power dynamics when paramedics patch to physicians and physicians talk to other physicians. It's like, we're all human, and we just got to look at what's best for the patient and the circumstance.
I will say the most helpful feedback I've been given in terms of when those interactions are going not the way you want them to, you bring it back to the patient. And everybody who works with me knows I've more than once on the phone said, I'm asking for help. The patient in front of me needs X, Y, Z, and I'm coming to you as the expert. And it tends to just de-escalate that whole situation. I do the Michelle Obama, they go low, we go high. So my voice gets real low and slow, and I try and take any kind of emotion out of it, and I bring it right back to the patient. It's about the person sitting in front of us. However you feel about whatever care was delivered, I was doing the best I could for the patient in front of me. And I'm asking for help.
Good line. What a good line. Like, I don't know, like you can't rebuttal that. You're like, wow, that is the most straight to the point, non-confrontational. I'm being vulnerable. I need help.
Yeah, I think there has to be huge vulnerability in healthcare these days. There's so much we can't know. And there's so much that we need help with, that we need to really be cognizant of our area and stay within it. As you said, there are many specialists that we've all had the privilege of working with and listening to, and knowing that.
If we look at women, how does that compare for their analgesia in comparison to like men? Like, do they get undertreated? You did mention that already, but why and how come?
It's a great point. And I mean, there are many studies looking at digesting this, and I think it's so multifactorial as to why women, and I mean, we're just talking in the binary sense here, which we all know gender is a spectrum. And I hope we all know that gender is a spectrum. You can tell where I stand on that. But just looking at the very binary man, woman, which a lot of these studies do, because they were done in the, early aughts or before then, a lot of them were done in post-operative settings in terms of pain control there. And there's this awesome scoping review that I think looked at like 20 plus years of analgesia in the post-op setting, and noted that women often reported higher reports of pain on pain scales, and then received lower doses of analgesia compared to men, which is incredibly interesting. Or if we even think about how we treat pain associated with typically women-based organs, or like female-based organs, if we talk about childbirth, or IUD administration, like all of these things, which I know is coming up more and more in the media as the FDA has approved male birth control. It was immediately approved for analgesia. If we look at IUD insertion historically, it has never been approved for, or rather never been even considered for analgesia. And yet it's a notoriously painful procedure. So again, it's a huge cultural thing that women's pain is different than men's pain, rather than just pain. Similarly, we think about our biases and we extrapolate those to racialized groups. I wish I had the paper off the top of my head, but there was this study done looking at medical students' perceptions of pain in Black versus non-Black individuals. And they had grossly inaccurate assumptions about the physiology underlying pain, such that Black person's skin was thicker. This is not true. So all of these assumptions, or understanding or learning about different groups of pain and how different people respond to pain is layered with assumptions about age, assumptions about gender, assumptions about race or ethnicity. And often they are not based in fact. And so we really need to work, as you said, is just learning and educating ourselves more, and recognizing our biases and trying to combat them, learning more around pain. I mean, certainly certain cultures and ethnicities have different preferences in terms of pain scales. We know this. There's data that supports that. What I mean is in like Europe and North America, we like, for the adult speaking population, we like a numeric rating scale, which is what we see in like our compendium document and stuff. It's the 0 to 10, rate your pain. We're all very familiar with it. There's a couple studies done in Asian countries which show that they preferred a visual analog scale, which is like the color bar often, and patients indicate where they are on the visual analog scale. Sure, there are cultural differences in that, but I'm not talking about a different pathophysiology of these persons that necessitates their pain shouldn't be treated or shouldn't be as valued or as recognized as before. It really comes back to just reflective practice. And you'll hear me talk about this a lot, but anybody who's listening to a podcast about their profession is probably a reflective practitioner, right? This isn't mandated by anybody. So I think I'm speaking to people who are already converted in this, but it's really understanding where your biases and your blind spots might be about how you're treating somebody and reflecting on whether or not those are evidence-based or those are maybe assumptive. And then looking at how we mitigate that. And we need to believe that when people say their pain is a 6, just treat them as their pain is a 6. What is the harm in treating pain, I guess, is the other. If we look at the flip side of the coin, what is the harm in believing someone's 6 is a 6 and treating that as a 6?
So you tell me, let's look at the first aspect. If I leave you at a 6 out of 10, and in my head, I'm like, I'm not giving you Advil and Tylenol. What could happen, and what could happen to their outcomes? I
mean, we know that they have worse satisfaction reported, worse outcomes in terms of their overall care. And there's often, I think, and I don't have a paper for this, that shows that within that stay or within that injury related, once that's transferred over to me, I might not be as readily responsive to that pain scale because another provider wasn't as responsive to that. So there's 6. I was like, oh, they weren't that bad. Their pain wasn't that bad. And that might kind of snowball into my treatment of their pain. I don't know. That's more of an assumption on my end. But I mean, I guess if we then look at what happens if we do treat their pain as a 6, what's the harm? Let's side effect. If we extrapolate, if you use the right agent, appropriate for it, that meets all of the indications, no contraindications, appropriate dose, right route, what's the harm? Nothing. It's not like we only have 3 doses and I only have 3 doses for my whole shift and I can't give out, like, I don't want to use it on the wrong person. Like, this is not a scarcity mindset. Despite what's happening with some of our medications in the province lately, it's not a scarcity mindset. So, for myself, I'm trying to be a lot more understanding of treating someone's pain as they state it. Because I have more doses I can give. I can make their pain better. I can improve that symptom and I can help their suffering in some way.
If we look at Advil and Tylenol, why are those 2 medications combined so good? I know we've said it a bunch, but I think it's very beneficial to keep hearing it because I think just the optics of giving oral medications, whether you're in the emerge or in the pre-hospital setting, like, that's not an emergency. It's so funny. It is. It's the low potency phenomena is what I want to call it. And yet most of us, when we're at home and we could have partially amputated a finger, we're like, grab the Tylenol 400 Advil right away. Like that's my home dose. And I wish that was a combined medication. I wish that was a combined pill. Anyway, that's an aside, but it's great because as we move towards talking about multimodal pain management, you're layering on how you manage these different entrances to the pain pathway, if we think about it. So you're addressing different modalities of their pain with these 2 medications that have relatively few
side effects, again, when dosed in the right person and when it's the adequate dose, but have relatively few side effects and a lot of benefit from it. Appropriately dosed Tylenol and Advil can really diminish pain. Plus, they have several hours of duration. Your dosing frequency is less than your IV meds often, or less than your opioids, and they're opioid sparing. So that reticence to give them as we cope with this huge pandemic of opioid toxicity, there's no reason not to give them. They're non-opioid meds. That's my spiel. Tylenol and Advil, backbone of the pharmacologic pain management spectrum. If someone can take oral, I mean, I guess you can use ketorolac if not, but if someone can take oral and if there's no contraindications, it's the mainstay and staple of what I'm giving in the department. And it's like a running dose that I have in the, the AIRS, electronic medical orders. I have a saved order that's Tylenol and Advil.